Hello, I'm Grace Bridger and this is my Unit 10 presentation for the roles and responsibilities of a healthcare professional, and I've chosen to base the presentation on the role of an occupational therapist. So the objectives, discuss the recent changes to the roles and responsibilities of an occupational therapist through role expansion, discuss how these recent changes have impacted the role of occupational therapy, discuss the role that professional bodies perform for those in an occupational therapy role, and then evaluate the effectiveness of the multidisciplinary approach in healthcare settings. So what is occupational therapy? So the Royal College of Occupational Therapy defines OT as a science degree-based health and social care profession regulated by the Health and Care Professions Council. Occupational therapy takes a whole person approach to both mental and physical health and well-being and enables individuals to achieve their full potential. So OTs treat people in a holistic approach to achieve meaningful occupations in everyday tasks that may become difficult due to disability, age or accident. So a brief history of occupational therapy. So William Rush Denton, so he was known as the father of occupational therapy, and he advocated for occupational engagement in the 1800s after using meaningful occupations himself during the healing process. And then in 1915, he wrote a manual explaining how to utilise occupational therapy for nurses. The benefits of occupational therapy were originally seen in the treatment of mental health patients, and that it didn't fit in neatly with other medical roles, as OT brought in aspects from physiotherapy, nursing, social work and psychiatry. Eleanor Clark Slagle, so she organised the first education and training programme for occupational therapy in 1915. This supported the transition for OT becoming truly recognised within the medical professions. And then during World War I and II, the benefits of using activities of daily living as part of the treatment process was realised, cementing the real value of occupational therapy as an effective treatment and profession. So recent changes to the roles and responsibilities of occupational therapists. Social, cultural, organisational, economic and political changes, scientific, technological innovations have impacted the way that occupational therapists work. So some of the social changes, so increased pressure on services, which is linked to public expectation and new discoveries of treatment options. Ageing population, so the average life expectancy has gone up year on year. Increase in demand for social care services for the vulnerable and the elderly, and there's also been an increase in costs for these services. An increase in patient expectation. Some of the economic changes, so prioritising services to reduce costs, so such as admission avoidance, rehabilitation services and essential only discharge planning in the acute sector. Changes in funding, changes in supply and demand, so OT is in more demand than ever due to the ageing population and an increase in mental health patients. Changes in the way services are delivered, so moving treatments that were traditionally in the acute sector out into the community. And then changes in the way care is delivered, so single-handed care is an example to reduce social care costs. Organisational changes, so the Francis report, which was completed in 2013, examined the failings of the Mid Staffordshire Foundation Trust, which led to a change in attitude towards compassionate care and whistleblowing, and it led to tougher inspections by the Care Quality Commission, which is also known as CQC. So CCGs, care commissioning groups, they replaced the Primary Care Trust in 2013, and they're now responsible for planned hospital admissions, rehabilitation services, emergency and urgent care services, community healthcare services, and then lastly, mental health and learning disability services. In 2001, the Modernisation Agency established to support the modernisation of the NHS, which led to the expansion in job roles and skills to increase patient experience and support greater outcomes for patients. So this led to new specialisms and an increase in collaborative working. Technological changes, so there's been an increase in diagnostic equipment and investigations. new medications. So this can impact OT, and I've just given an example of Parkinson's disease. So if you've got a patient that's come into hospital with Parkinson's who for whatever reason hasn't received their regular Parkinson's medication, you wouldn't necessarily go and assess them straight away because you're not going to get a true reflection of that patient. So you'd probably wait until they've had at least a few days of their regular dose of medication and then go in and assess it, because then you're going to get a real picture for what the patient's like. New equipment on the market, especially to support single-handed care and increase independence. So I've just given an example here. So this here is an ETAP MoLift. And traditionally what was used is something called a rotunda, which did require 2 carers. And then this was brought out and it only requires 1 carer. So it's actually been able to reduce the care costs. So someone that traditionally needed 2 carers 4 times a day may now only need 4 carers and 1 going each time. New electronic systems in place. So instead of using the medical notes to document, quite a few healthcare professionals now use an electronic system to document their contacts with patients. And it's increased the communication between trusts and different services. So from acute to community services, it's just made communication a lot easier. So political changes, the NHS Act. So in 1946, Clement Attlee brought the NHS Act before Parliament. He believed that healthcare should be accessible to all and free at the point of access. So this meant that then doctors, nurses, physiotherapists, occupational therapists, radiographers, all these different professions were now available and in reach of patients across the UK. The NHS and Community Care Act. So this saw the introduction of market forces with GP-funded stakeholders and district health authorities becoming purchasers of services. And then through auditing, this increased good practice and supported the transition for some services to go from the acute sector into the community. And then the Patients' Charter in the 1990s. So this listed the rights and responsibilities of patients and also the rights and responsibilities of the healthcare professional. So this highlighted that, you know, healthcare professionals shouldn't be abused whilst they're working, but also that the healthcare professionals have a right, should treat patients with respect and dignity, and that patients should be enabled to have a choice within their own care. So how have the recent changes impacted the role of occupational therapy in terms of role expansion? So one of the roles that was developed, which wasn't occupational therapists themselves, was the OT support worker. So this role was developed into another position called an OT assistant practitioner, which meant that the support worker had their clinical skills developed and were able to clinically reason through decisions. So they could pick up a patient on admission, or if it was the first time that the service had seen a patient, and follow that patient through up until discharge, as long as they worked under the guidance of an occupational therapist. So this helped lower the pressure on the occupational therapists, because obviously their workloads had increased. And then specialities. So there's lots of different specialities within occupational therapy now. Trauma and orthopedics, mental health, elderly care, paediatrics and respiratory, to name a few. And that occupational therapists now can become safeguarding managers, senior NHS managers, OT consultants and counsellors. So the role's been developed. So OT support a wide range of patients, and the ever-increasing pressure of the acute hospital setting, certain services have moved from inpatient to outpatient services. So traditionally, if you had a stroke patient that come into hospital, a lot of their rehabilitation would have taken place on a rehabilitation ward. However, these wards have now moved out into the community. So patients are now treated acutely and they're now made well enough and active enough to leave the hospital, and then they're usually signposted to other services which have now moved in the community. OTs are now employed in health organisations, social care services, housing, education, voluntary services, or as independent practitioners to increase their reach of providing services in line with health equality. So OTs perform a number of different roles, They can help write care plans for social care services. They can go in after someone's been discharged from hospital and do an OT assessment there to see if they can reduce the need for care by providing equipment or teaching a patient a different way to do something. They can also help with housing, so with homelessness and immigration. They can help support patients with that. So as you can see, as I've explained, OTs have a great reach and provide support to a number of different people through lots of different services. So financial impact. So one of the positive changes on the OT profession was the introduction of Agenda for Change, which meant that the average wage for OTs it increased. So in around 2001, the average starting wage was around £19,000, and the average starting wage now is around £25,000. OT is a profession which has one of the biggest influences on costs. So through the change in settings of services with the aim to reduce the overall cost of hospital admissions, OT they play a vital role in the efficiency of hospital flow. And within the hospital settings, there's different teams. For example, front door teams are now in place to they're also known as admission avoidance, so that if someone comes into A&E, they can have if they're medically fit to go home, they can have an OT or a physio assessment, and that patient can then be discharged back to their own home straight away instead of being admitted into the hospitals. So OT support with the discharge planning process, providing essential support and equipment to facilitate discharges while continually aiming to reduce the length of stay and refer or signpost patients to services to continue with their treatment. Due to the increase in costs of care, OTs now conduct many social care assessments within the acute and community setting to reduce the long-term costs of care. OTs are highly skilled professionals who can pull from aspects of different medical professionals to provide a holistic care plan and treatment process for patients as they consider all aspects of the patient's needs. So occupational therapists are now more accountable for their actions more than ever. OTs have to clinically justify all decisions they make in regards to care and treatment and that they provide for a patient. And there's been a marked increase over the years in the amount of documentation that needs to be completed. OT is also a registered profession, so they are answerable to the HCPC and RCOP professional bodies. There's an increase in accountability all over healthcare professions who have to follow strict policies, procedures and codes of conduct. And due to this, the NHS themselves have introduced some new policies. One of the main ones is the 6 Cs. So that's a general code of conduct that all NHS staff has to adhere to. So the 6 Cs, an example of some of them is care, competence, commitment, courage and communication. And the staff are expected to be an example and use these 6 Cs to provide the best care that they can for patients. So the role of professional bodies and what do they do for healthcare professionals? So the main responsibility of a professional body is to promote and maintain public safety by ensuring standards are in place. Professional bodies can also give restraints and requirements to healthcare professionals and practices which can be enforced. So just to start with, we'll go to the Health and Safety Executive. So they're a national independent regulator for maintaining health and safety in the workplace. Mandatory guidelines based on relevant legislation. Guidance and completion of risk assessments for tasks and situations such as manual handling, slips, trips, falls, sharps injuries and managing challenging behaviour. No enforcement role covering whistleblowing. However, a protective disclosure can be made. So that means that if there is a concern raised about the workplace, you can report them to the Health and Safety Executive. The Care Quality Commission. So they're responsible for the regulation of quality and safety of health and social care provided by the NHS, local authorities, private and voluntary sectors who provide care under the Care Act. So they rate providers on the following standards: person-centred care, dignity and respect, consent, safety, safeguarding from abuse, food and drink, premises and equipment, complaints, good governance, staffing, fit and proper staff, duty of candour, display of CQC ratings, and their inspection framework is safe, caring, effective, responsive and well led. So the service will be assessed on the inspection framework and given a rating, and then they either have to improve on the rating of which they've got, and that also has to be displayed clearly within the setting. So the HCPC, so the role of the Health and Care Professionals Council is to ensure healthcare professionals adhere to the following standards. So conduct, performance, ethics, proficiency, continuing professional development, education, training. And they also approve programmes that professionals must complete in order to register, take action when professionals on register do not meet the standards, and they are also there to support whistleblowers. So the Royal College of Occupational Therapists, so they set professional standards for occupational therapists, and some examples are to value diversity, treat practitioners and patients fairly and without discrimination, duty of care, to update knowledge, skills and abilities, to maintain accurate documentation, demonstrate professional rationale, delegate to competent persons only, take reasonable steps to maintain safety, welfare and health of those under their care, raise concerns, and to always act in the patient's best interest and uphold their human rights. So the effectiveness of the multidisciplinary approach in healthcare settings. So ideally, the MDT should consist of all professionals involved in a person's care, including doctors, nursing staff, therapy staff and social care staff. These meetings are used in a variety of different circumstances, ranging from palliative to complex care to daily ward round meetings. They're used to discuss patient care, solve issues or delegate tasks and aim to achieve positive outcomes for patients. So some of the advantages of the MDT approach. So treatment is based on a variety of ideas and opinions, continuity of care, clinical management protocol becomes embedded within this care, continuous audit of interventions and outcomes, communication opportunities to speak with other disciplines, professional knowledge and expertise shared, can encourage a sense of partnership, especially in management of complaints or complex cases. Some of the disadvantages of the MDT approach. So traditional power bases are weakened, especially when acquiring resources. Shared goals overshadow goals specific to different disciplines. Less time for reflective practice, team building and development. Difficulties in balancing communication and listening. Individual contributors feeling that their treatments take priority. Lack of team leadership and frequent change in team members can lead to a decrease in positive patient outcomes, and problematic team members can waste time and hinder progress. So I thought it'd be really interesting to speak to some of my colleagues at work about some of the challenges that they feel they face as therapy staff within the MDT. So I spoke with some of my occupational therapist colleagues and also some physiotherapists, and these were some of the themes that I identified. So other disciplines do not understand the role of occupational therapists and physiotherapists, can be confused with social care staff, so with other team members assuming therapy staff are responsible for some tasks which are allocated to social workers. No differentiation between therapy roles, so that they're all assumed to do the same thing. So occupational therapists and physiotherapists are often confused to be the same role and do the same sort of things. As therapy staff tend to care for a patient holistically, other team members may not understand the purpose of some of the treatments that they provide. Sometimes a lack of respect for the importance of occupational therapy and physiotherapy, and some of my colleagues stated that they felt that it can be seen as a bit of an afterthought or unnecessary. And some of them felt that there was a hierarchy within the MDT, and therapy staff can feel quite low down as if their input isn't valued. So one of the positives that did come out was it's been noted that MDT meetings do increase person-centred care, which has led to greater inclusion and respect for the input of therapy staff in general, resulted in further job opportunities such as management roles in rehabilitation settings, which were traditionally given to experienced nurses. How to make the MDT approach effective. So be respectful of other roles and disciplines within the team, be respectful of skill set and expertise, be collaborative, treat the patient holistically and focus on person-centred care. Allocate a key member of the team to lead the discussion, include the patient themselves if appropriate, be open, honest and manage expectations, be respectful that professionals an idea of treatment may not be in line with the patient's wishes, enable choice and uphold human rights. And there's my references. Thank you.